Thank you very much. Good afternoon, everyone. I'm very happy to be here today to do this introduction to this exciting session. So, as we can see today in the room, we belong to an extremely nice but quite small community. And it's true that pulmonary sarcoidosis and ILDs are rare disorders, but their incidence and burden of disease increase a lot. According to this big data study collecting data from all over the world, the incidence of pulmonary sarcoidosis and ILDs has increased by 120% over the last 30 years. Mainly in patients over 75 years of age, and in countries with a high social demographic index, that is in most developed countries. There is also an increase in the rate of mortality and an increase in burden of disease as estimated by DALYs, disability adjusted life years. And when you look at all chronic respiratory disorders, pulmonary sarcoidosis and ILDs have the highest increase in burden of disease over the last years. So there are many challenges currently for a clinician in ILDs. Some of them have been already addressed in the previous sessions, and others will be discussed in this session. Obviously, it is critical to make an early diagnosis, and there are several ways to try to achieve that. I think we should inform and educate the GPs and the non-expert pulmonologists to try to improve networks of expert ILD centers at country level, and also to try to reduce socio-economic and environmental inequalities in order to provide best care to all our patients. Once the patients have been referred to our referral ILD centers, we can still do much better than what we do today. Multidisciplinary approach remains for now the gold standard for the diagnostic of ILDs, but as demonstrated in this very nice study, it's not a perfect approach. In this study, the diagnostic agreement between 7 international highly experienced multidisciplinary teams was, as you see, quite poor. And in addition, classifications have very many limitations, and I'm not sure that we really use the same language. For example, for the terminology of provisional diagnosis or for the terminology of unclassifiable ILD. So how can we improve the diagnostic accuracy in the future with precision medicine? Diagnostic biomarkers will probably help us, but the problem is that we do not have ideal biomarkers that is accurate, reproducible, non-invasive, easy to measure in routine, and cost-effective. I guess that molecular biology will play an important role, and all of you know the genomic classifier Envisia, which is supposed to give a diagnosis of UIP with a high specificity by the analysis of transbronchial biopsy. The problem is that you still need an invasive lung sample for that. We talked a lot of artificial intelligence during this Congress, and I don't know you, but I have to confess that I don't understand everything of deep learning. The only message I can get is that the performance of a machine is better than that of our radiologists, which is quite exciting, but also a little disturbing from my point of view. So in terms of treatment, I think that we really need to put the patient at the center of care, to share decisions with him, and to try to have a more global or holistic approach, including end-of-life care. And we learned a lot from the oncologists in this field. The phenotyping of ILDs is essential not only for researchers but also for clinicians. And from this point of view, the recent concept of progressive pulmonary fibrosis is a real step forward because of the possible use in these patients of antifibrotic treatment. But this concept has many pitfalls. And for example, I'm not sure that it may apply to fibrotic pulmonary sarcoidosis, where we don't know the rate of decline and where we don't know if there is only self-sustaining fibrosis or also ongoing inflammation or even other causes of respiratory worsening. In the future, we have to find prognostic biomarkers, reliable prognostic biomarkers, to predict progression and to identify patients. We will respond to treatment, in particular to antifibrotic treatment. So, to finish with artificial intelligence, I was very much impressed by this study published very recently in Nature Communications, where a very complex model integrating not only CT images but also clinical information such as history, PFTs, echocardiography, treatment at baseline and during follow-up, was able to give a diagnosis of ILD with a high precision, but also to predict 3 years survival. So maybe one day we will just have to enter into the computer clinical information, the results of selected biomarkers and longitudinal results, and just click on a button and say, what is the diagnosis of my patient? What is his prognosis? And how should I treat him? And it's my ChatGPT. The ChatGPT has already been discussed previously. This is my last dia. Thank you very much.
Thank you, Ilario, for this very challenging presentation. And I still hope that ChatGPT will not replace all of us, but we'll see that. Is that you have a question?
I had a brief question and comment, Ilario. I know you were trying to escape.
I'm doing the introduction. I'm not supposed to reply to the questions.
I agree it's a nightmare that the receptionist will come to the patient and say, the computer will see you now. And I agree about that, but I imagine that's why you're a bit alarmed that they're doing better than radiologists. But we have a huge amount to learn from them, don't you think? So with unsupervised learning, the processes
for the non-experts.
Processes picking up signal that experts can't see, and the challenge is decoding it. So in the deep learning, we may get new signs for experts to use. The computer may be picking up CT signs of lung senescence in identifying UIP, or doing something with the vessels. So I actually think that rather than a threat, it may be an opportunity. We may get quite a lot out of it as human observers in the end.
I will be dead at the moment we can use it.